I welcome you to the IABP Counter-pulsation therapy webinar that is going to be facilitated by Dr. Yemi Johnson. Dr. Yemi Johnson is a seasoned interventional cardiologist. He graduated from the College of Medicine, University of Lagos in 1980, and he began his postgraduate training at Yale University, New Haven, Connecticut, USA, where he was enrolled in the Masters in Public Health and Preventive Medicine program. He underwent his internal medicine residency training program as well as his cardiovascular disease fellowship training program at the College of Physicians and Surgeons of Columbia University, New York. He became a diplomat of the American Board of Internal Medicine in 1987 and of the American Board of Internal Medicine Cardiovascular Disease Subspecialty in 1989. He subsequently underwent interventional cardiology fellowship training at Loma Linda University Medical Center, and he became the director of vascular cardiology at Mid Carolina Cardiology, and is credited with the initiation of the peripheral vascular intervention program at that institution. He was appointed associate clinical professor, Wake Forest University Medical Center in Winston, North Carolina in 2006. He relocated to Nigeria in 2008 and he founded the First Cardiology Consultant Limited. He pioneered the contemporary invasive cardiology in Nigeria. He has performed several procedures, including the first coronary angioplasty with stent implantation in Nigeria, first non-surgical percutaneous closure of holes in the heart for children and adults. He now performs these procedures routinely. Dr. Johnson has also established a non-surgical peripheral vascular disease program to restore blood flow to blocked arteries of the arms and legs. This program has helped salvage several limbs which hitherto would have been amputated due to poor circulation. Please welcome Dr. Yemi Johnson to facilitate the webinar. Thank you, sir. Welcome, sir. We appreciate your time for this.
Thank you. Can you hear me?
Yes, sir.
Are my slides showing or am I not yet sharing my slides?
Your slide is not yet showing. You can share your slide now. So
share screen. All right. Is it showing now?
Not yet, sir.
How about now?
It's coming up. Yes, we can see your screen, sir. It says intra-aortic balloon counter-pulsation. We can see your screen, sir.
Okay, good afternoon, ladies and gentlemen. Welcome to this webinar on intra-aortic balloon counter-pulsation. I am speaking from Accra, Ghana, one of my favorite cities. So my job is to introduce this procedure, this concept of intra-aortic counter-pulsation as one of the methods of mechanical circulatory support. There are several of them. There's intra-aortic balloon pump, there's the impeller device, there's the ECMO, and there's the ventricular assist devices. But today's topic is on intra-aortic balloon counter-pulsation, and I will talk briefly about the the other devices. So I presume many of us are familiar with this. Some are not. Some are experts at this already. But let's just go through the basics. So, as is depicted in this slide here, it is a balloon catheter. So there's the balloon. I can't I can't point here, but there's a balloon catheter on the left of the screen. Uh, uh, the bottom part is connected to the console, which is shown on the right. And then the distal part, which is the balloon, you can see a long balloon in the distal part of the catheter. That is inserted into the descending aorta, usually through the femoral artery. So the where you put this balloon, the tip, if you look on the right X-ray, you will see a circle around the tip of the balloon catheter. That should be just distal to the left subclavian artery in the descending aorta, or between the second and third rib. That's usually how you estimate where it should be. You don't want it to go beyond that, because then you are occluding, you are at the arc, and you don't want the inflation to occur at the arch of the aorta. Sorry. So, so what is this device? What does it do? Basically, like you can see in this diagram, that's the inflated balloon in the descending aorta on the right side there. You can see the tip is distal to the left subclavian artery, and then it comes all the way down distally, just below the renal arteries. Okay, what it does is when it inflates, which is during diastole, it inflates, it displaces a significant amount of blood. So basically, it's a volume displacement pump. It inflates, it displaces blood, and blood during diastole goes backwards to the proximal aorta, and it retrogradely fills the coronaries during diastole. And as most of you know, coronary perfusion is mostly during diastole, not systole. So this is how it works, and I will show you how all these things affect us physiology. And all this is connected to the console. The balloon is filled by a helium, which is non-toxic in case the balloon pump, ruptures. The helium will not cause any trouble. Okay, this is a diagram, a little animation of what happens. This is the balloon pump in the distal abdominal aorta, and you will see it going, uh, inflating during diastole. Blood goes backwards, fills the coronary arteries. And during systole, it causes a negative vacuum, and it reduces systolic pressure and reduces afterload. So it reduces afterload during systole and increases diastolic flow during diastole. So that's basically how it works. Increases myocardial perfusion, coronary perfusion, oxygen supply to the myocardium during diastole, and in systole, it reduces afterload. Okay, now this is the hemodynamic tracing. Those of you are familiar with an arterial line, this is what it looks like with the intra-aortic balloon pump in place. Now note that, let me just go through this. You see the first number there is 52, all right? That is end diastole, okay? Then 102 is the systolic blood pressure, right? That the 116 you see that waveform. You see that's during diastole. That is the augmented diastolic pressure during diastole, which is what fills the coronary vessels for increased perfusion. And then the 43 there is what happens with the once the balloon deflates and
It
at the end of
seems your
diastole before
slide,
systole.
I think
Sorry.
we are stuck at the slide where you have the video.
Mm.
Yes, sir.
What about now?
Okay. Yes, we are timing assessments.
Okay, let's start again.
Okay, sir.
All right, this is an arterial line tracing. All right, let's go with the first number you see, 52. That is end diastolic pressure just before systole in without the augmentation of the balloon pump. 102 is the normal systolic pressure. All right, now 116 is the augmented diastolic pressure. All right, with the balloon pump during diastole. Okay, then 43 shows how low the pressure goes down just before systole when the balloon deflates, and that's what helps reduce the afterload. I hope I'm making sense. And then it goes on and on like that. This tracing here is 1 to 2 timing, which means it is every other beat, every other cardiac cycle that the balloon pump augments. Usually, when the patient is sick, we do it every cycle. But this one, just to show you how it works, this is every other cycle. So, what to note about this, you will see the highest pressure here is diastole. So, when you use your regular blood pressure cuff to measure blood pressure, it will give you a false blood pressure. So, when the balloon pump is on, the non-invasive blood pressure measurement is very inaccurate. So note that the augmented, it doesn't reflect what's going on in the hemodynamic system of the body. Okay, this is that. Did it move to the next slide now?
Yes, sir.
Okay, good. All right, so this just illustrates it a little bit more. So what happens in diastole is you get increased perfusion pressure, increased blood flow to the heart, and increased myocardial oxygen supply, which is very important. All right. Now, during systole, sorry, that's my Siri answering me. I don't know why. So hold on. My phone is okay. My phone was answering the questions. All right. Um, Now, during systole, you get increased, your afterload is reduced, all right, which helps cardiac output. Left ventricular end diastolic pressure is also reduced. Now, remember, in heart failure, left ventricular diastolic pressure is usually very elevated, either in diastolic or either in reduced ejection fraction or non-reduced ejection fraction, diastolic dysfunction. Heart failure usually represented by increased left ventricular end diastolic pressure. It increases cardiac output and reduces myocardial oxygen demand. So this is in effect what the balloon pump does. So if you look at it from a practical perspective, after you put in the balloon pump, you will find out that the following hemodynamic changes occur. Cardiac output increases, cardiac index increases. This is usually measured by Swan-Ganz catheter, which many ICUs have nowadays in Nigeria. So you will notice your cardiac output increase, your cardiac index increases, your saturation pressures improve, and you get an increase in cardiac output to about 1.4 liters per minute. And this is all measurable by the Swan-Ganz catheter. So you see, hemodynamically, in reduced cardiac output, this is a very valuable tool. Now, just a little bit illustration here. The trigger, it is triggered by the ECG or by the arterial pressure. ECG is usually preferred. That's why it's important to have a good ECG connection on the machine with your electrodes and leads well positioned. So it is triggered, you see, during systole, and then, it during diastole, the balloon starts to contract at the dicrotic notch. All right, that's when it contracts, and then the pressure goes up, and then at systole it comes back down. All right, this is very important. The timing is important. I won't go into the timing because that's a little bit more advanced. We're dealing with the introduction of the concept, but the timing is with the ECG, so it goes in with the cardiac cycle. Um, can you see the next slide? You see,
Yes,
okay,
sir.
I assume you do. So you see the first label there is dicrotic notch. So those of you used to the arterial line, dicrotic notch is where inflation starts. And you see the next ECG, the next QRS, you see B is normal systolic pressure, D is the augmented blood pressure during diastole. So remember, when you have a balloon pump in, the highest blood pressure is usually the augmented pressure in diastole. So what are the indications of to use a balloon pump? They're in three general categories: acute coronary syndrome, Cardiac and non-cardiac surgery. Um, that is in patients undergoing non-cardiac surgery who have cardiac issues like reduced ventricular function and you want to stabilize for surgery. Sometimes we use that. And then complications of heart failure, in other words, cardiogenic shock. All right, so examples include unstable angina, not responding to medical therapy, uh, impending infarction, which is also a type of unstable angina, post-infarct angina, and complications of an MI, which include VSD. Uh, where it's not the treatment for a VSD during after a cardiac after an MI, but it can help you stabilize the patient while you prepare for surgery. All right, and we oftentimes use it in high-risk interventional procedures. Okay, now I think for us at FCC, most common use of the balloon pump is to help out during surgery, the high-risk surgical patients with severe LV dysfunction. That is, I think that's the most often, that's the highest indication we use it for cardiac surgery. People with poor LV function, high risk. So we use it to try and reduce the risk of surgery and help the patient come off the balloon pump. Sometimes it is inserted, oftentimes before surgery, sometimes after surgery when the patient is having difficulty coming off bypass. So that is one of the indications, one of the most frequent indications for using the balloon pump in our place. The other indications usually cardiogenic shock, and then for use in high risk angioplasties. And when we do our high risk angioplasty, we do not usually put it in at the beginning of the procedure. We have it on standby, ready to put in case the patient becomes unstable. In patients who have severe pain, unrelenting pain, ECG changes, we tend to put it in before the angioplasty or before the angiogram because once you go in and you put a wire across any lesion, perfusion goes down and the patient becomes unstable. So that's when we tend to use it. And now this slide says indications outside the US. In the US, they have the other devices, the impeller, the ECMO, and all these things. So they don't use it as much as we do here, and that's mainly the economy, money. The other devices are very expensive, and I'll show you that a bit later on. So this is just to show you, and I hope my guys who work in the ICU will understand this slide. Um, Mechanical support is usually better and safer and improves prognosis as opposed to using high dose of inotropes. Like when we turn on um, dobutamine, dopamine, noradrenaline, adrenaline at high doses, they tend to cause more damage than good. And it is better to put in this device early on in the cardiogenic shock uh, cycle. When you put it in at the end, when you're already maxed out on these inotropes, usually it's too late to help. So it's important to put this device in, initiate the device when you see the cardiogenic shock starting, not after kidney function has failed, there's liver failure, uh, there's metabolic acidosis. By then, it is usually a little bit late. Put the device in before then, and it will improve your outcomes. So just to emphasize what the high dose inotropes do in cardiogenic shock, you can see this long list. But one, they increase myocardial oxygen demand. All right. Two, they are pro-arrhythmic. Anybody who uses those drugs notices when you get tachycardia, and then you get VTAC, you have SVT, you have AFib, all manner of arrhythmias show up. All right. Now remember, tachycardia is a response of the body to improve cardiac output. But when the heart rate goes too fast, there's not enough filling time in diastole to fill blood into the left ventricle and pump it out. So the tachycardia tends to have a negative effect, reduce perfusion, and causes more trouble. They all cause severe vasoconstriction, which increases cardiac output. I mean, increases afterload, reduces cardiac output. So remember, it is better to put this device in early before you max out on dopamine, norepinephrine, and epinephrine. It just generally it's more helpful because these drugs will improve blood pressure initially, but then everything falls apart because of their side effects. All right, and so what are the possible complications? Number one is limb ischemia. It's a big device, usually between 7 French and 9 French, depending on which one you use. So you put that in the femoral artery. It is going to reduce blood flow in that vessel, period. It is. So it's important to check the pulses after you put the device in. That is why one of the contraindications is severe peripheral vascular disease, because it could be occlusive and you end up with severe loss of blood flow to that limb. And sometimes the patient can develop severe limb ischemia and lose that leg. So it's important. You monitor the limb, you monitor the vascular pulses, especially dorsalis pedis and posterior tibialis pulses. It is critically important. You should have a Doppler. All the balloon pumps have a Doppler in the console. So you should be able to listen to the pulses. You might not be able to palpate, but you should listen. This is critically important. Another common complication is bleeding at the insertion site because one, once you put this device in, you have to understand that full dose anticoagulation comes in, usually with Clexane, all right, or heparin. You need to anticoagulate fully because there's a high risk of thrombosis with that device, that big device uh, in the aorta. All right, oftentimes there's thrombocytopenia. Sometimes the balloon pump won't function; it will just stay there, and when it is not moving, it attracts blood clots. Infection, another common cause. That's why we try to limit how long you put it in. Do your best to make it a sterile procedure. Many times when we're doing this procedure, it's an emergency and sterility is compromised, but infection is a common complication. When I say common, I don't mean everybody, but it's one of the complications. A rare complication which I have not been privileged to see is aortic dissection, because putting in device, you can dissect the aorta, and sometimes the balloon ruptures. But like I said, we fill it with helium, so helium does not cause any trouble in the circulatory system. Contraindications. Number one, aortic insufficiency. So remember this. Aortic insufficiency is probably the number one complication. I mean, contraindication. And why is this? Remember, during aortic insufficiency, the valve leaks. The regurgitation happens during diastole. All right. Now, when you inflate the balloon during diastole, you increase the aortic regurgitation and make it worse. So that's a big no-no. Cardiogenic shock with aortic regurgitation, you cannot use the balloon pump. You can use the other devices like ECMO, but definitely not the balloon pump. All right. Abdominal or thoracic aortic aneurysm, another no-no, because you could rupture that aneurysm and cause more trouble. Severe aortoiliac disease is a no-no because it's a long balloon. You might not be able to guide it down up, all the way up to the distal aorta and to the distal subclavian, distal to the left subclavian, and trying to force the balloon through, you could perforate and uh, hurt the patient more. All right. Obesity is always a problem for any procedure. Okay. Now, let me, I hope you can see this last slide here. Just to give you an idea of the cost. I asked everybody for the cost. Nobody would give me the cost, but I found this online, and this tells you why we don't have it in Nigeria yet. Balloon pump, first one there, estimated cost $5,000 to $10,000. All right, readily available. We use it a lot in Nigeria. Impeller, 25 to 40,000, just for the device to be purchased. Now, using it we can run you another $50,000 during that hospital stay. Not yet available in Nigeria. The cost is prohibitive, and it requires special training. But it is a very useful device. ECMO, another important device. You can see the price there, $40,000 to $80,000, and you need training. Oftentimes, it's a proficientist who knows how to use the ECMO device. It is very similar to the functioning of a heart-lung machine. So it requires expertise to put in. We had it briefly, but we don't have it any longer. And it's a very useful device, but it's very expensive. And then the VAD, that is ventricular assist devices. Those are $100,000 plus. And maintenance over months to years could run you another $500,000 to $1 million. Not yet available in Nigeria, but the goal is to have all these available in the next few years as we increase cardiovascular activity. As all of you know, cardiology, cardiovascular surgery, interventional cardiology is ramping up in Nigeria. We're doing a lot more volume. These things will soon become available, as well as other things like TAVI and mitral clip. They will soon become available as all of us ramp up a number of procedures we do, and the cost of doing all these procedures comes down. So that is my presentation for today, and I'm ready for any questions.
Thank you very much, sir. So for the participants, thank you for listening. So at this point, if you have any questions, please, you raise your hand. You can raise your hand with the icon raise, and then you will be unmuted, or you post your questions in the chat. So I have somebody, Dr. Bode Falashe. You can go ahead and speak, sir. Dr. Falashe, you can go ahead and unmute and speak.
Okay, can you hear me now?
Yes, we can, sir.
Okay, thanks for a fantastic presentation as usual. I was just wondering about costs, which is always what we ask about. What is the availability of balloon pumps in Nigeria? Which brands? Is it the Getinge? And for the catheters, what is available and what's the cost?
Who's that question to, me or GNCI?
Anybody.
I think GNCI will answer that question.
Okay.
Okay. I will answer the question, sir. So, so the brand that GNCI markets, and I think that is the brand that is currently as install base in Nigeria, is the Getinge brand, which is the CardioSave. However, we have the older models of C300, C100 in Nigeria, but they are old. They are no longer supported by the manufacturer. So the current model is the CardioSave, and GNCI markets that. For the balloon catheters, we always have stock of the balloon catheters, and the stock cuts across different volume of balloons. So you have the 30, the 40 cc, the 30 cc, and also 7.5 French, or the 8 French, which is the mega balloon catheter that helps in displacing more volume to achieve and stays longer while it's inflated, and it's readily available. We always keep stock of that across the year. Does that answer your question, sir, Dr. Bode?
Not fully. You have mentioned the costs of the balloons. I also want to know, are these balloons backward compatible? You mentioned that the Getinge is the current version. You have the previous C100, C300. If we have those older consoles, do these new balloons work with them?
First of all, let me quickly address for the catheters. The catheters are about $800 for the catheters, and then they are compatible with the older models. They are compatible with modern models, and for our catheters that are not fiber optic are compatible with even other brands of IABP machine.
Okay, thank you.
Thank you, sir. Dr. John.
I noticed, Dr. Falashe,
Okay,
I
sir.
noticed he did not address the costs, sir.
No, he didn't.
No, he
I
bypassed
addressed
it, yes.
I thought I addressed the cost.
No,
Okay, of the machine.
no, and the balloon catheter itself.
The catheter I said about $800. And then for the machine, between 120 to 150 million, depending on how we configure.
Okay,
Naira.
thank you.
Yes, sir. Dr. John Adabe, sorry, Dr. Morris, can go ahead on mute to speak, to ask your question.
All right, thank you very much. Doctor, thank you very much for this wonderful presentation. So I just wanted to clear my doubts. So I was having a discussion with a senior person, and who feels that IABs are out of fashion with regards to ECMOs and other devices, and that there's no current guideline that support the use of IAB, even though I've seen the indications and things you brought up. Made a statement, there's no current guideline that support the use of IABs. So I just wanted to speak to it. I want to know much about it, the use of IAB, even though you've given the indications, the contraindications, and everything in regards to it. Is it still in use, or there are new therapies with regards to the indications you give?
Okay, that's a very important question. Yes, the use in the US, UK, the Western world has gone down. It's still in use, but it has gone down because they have the other devices, impeller, ECMO, and the VAD, usually the LVAD. We do not have those things here yet because the cost is quite prohibitive. That is the main yes. So yes, in the Western world, it's gone down, but it's still used, but not as often as it used to be. When I was still in the US many years ago, we used it a lot for almost any unstable case, high risk angioplasties. We used it a lot, and but now we have the impeller, which is available, readily available over there, but it isn't here. And it's one thing buying the device, it's another thing buying the consumables for the device, and then all the other things you need to. So we don't have that. Our economy has not reached that level. So we have to deal with what is available. And the balloon pump is still a bridge towards that. If you get ECMO, it's a different matter. If you get impeller, it's fine. But we just don't have those things yet. So we are not as contemporary as we should be in Nigeria, West Africa, because the cost is prohibitive. That is the main reason. So it is true, it is not in vogue. The use is going down in the Western world, but it is still being used, but not at the same volume as it was 10, 20 years ago.
All right, thank you, sir.
Dr. Oludbenga Ojo. You can unmute to speak.
Thank you very much. I just wanted to add to what Professor Yemi Johnson just talked about. So in Europe and America, and in most other climes, it is the IABP is becoming outdated, because over time they realized that the problem in patients who have cardiogenic shock and then post CABG or for any reason, the problem is really unloading the left ventricle, which IABP or even ECMO doesn't do so well. So and that's why the impeller device has undergone a lot of modifications. Now the impeller 5.5 is quite it's a smaller device and it's very easy to insert, even intraoperatively when after surgery, and then there are issues with coming up cardiopulmonary bypass. An impeller 5.5 can just be inserted, and then even if it happens post-op, it's also something that can be inserted percutaneously. I'm saying this because I remember Professor Falashe talked about some points when we had some meetings. If we don't request for something, we would not have, in volumes, we will not have the price go down as we have it 25,000 pounds or what is there on the screen. So if we continue to use what is outdated, we will never get to using these new devices. And the impeller has undergone a lot of transformation. As I said, the recent impeller device is quite easy to insert. And the beauty of it is that it saves you the stress of the LV dysfunction that happens. And in fact, there are some studies that have shown that putting an IABP is like just giving multiple doses of inotropes, and that even for patients who are on ECMO, over time, the LV just distends and needs to be unloaded. That is what the impeller 5.5 does for the patient. So I think, in my own view, what we should do is to aim to get this product into the country, try in places where adult cardiac surgery is being done regularly. And with time, I'm sure the price would definitely come down. Thank you.
We will, I think I will, okay, there is, okay, Dr. Falashe, please let me just take this person and then you will come up. I thought somebody muted. Okay, I will quickly ask Dr. Johnson, there is a question on the chat group, and then I will take Dr. Falashe again. The question says that, can you please explain the chart again? That's the systolic and diastolic of IABP.
Is my screen showing? I don't think so.
I will unshare so that you can quickly share that slide. So you can share your screen now.
Okay, is it sharing?
Not yet.
Not yet.
Maybe while you are, okay.
Okay, is this the slide you were referring to? Okay, I'm not hearing a response. Can you guys hear me there?
Precious, I don't know what this is. Is that the slide you're referring to in your question? I believe this is it because it says it's talking about systolic and diastolic.
Okay.
I see any slide.
It's not showing.
It's showing on this side. Maybe it's a network.
No slide.
I mean, I can see it.
I can see it as well.
Okay. All right. So I don't have the ability to point to where I want to point to, but look at the first QRS. all right, on the left side of the screen of the diagram. As you know what the normal QRS is, the beginning is the QRS, and what we're seeing is peak systole at the top there. Then pressure comes down, and then you get the dicrotic notch. And then this is all in systole, dicrotic notch, and then diastole starts right after that. And then you see end diastole, which is A. All right. Does that show there? Do you see my little
Yes,
pointer?
yes, it is.
Ah,
It is showing.
cool. Okay, I start again. So this beginning of the cycle, this is when systole starts. End diastole here, systole goes up, pressure goes up, and then it starts to come down. This beginning of diastole coming down, dicrotic notch. This is when the balloon inflates, all right, at the dicrotic notch. And then it deflates down here. So this is it with the balloon pumping. So systole going up like this, that you get to B at peak systolic pressure. Then pressure starts to come down. And as it goes down to the dicrotic notch, the balloon inflates. So this balloon is inflating during diastole and is increasing pressure to the coronary arteries and the myocardium during diastole. And then at the end of diastole, it starts to come down. And it goes down and goes down below what it was at the beginning. So that is what is supposed to help reduce afterload. All right, then you have the cycle starting all over again. And this is a 1 to 2 configuration. I hope it makes sense. Now, as to the, I can't remember Dr. Lugbenga, I think it was, who was talking about the impeller. I don't think anybody will disagree that that is the way to go. I think the volumes are increasing, and we shall soon get to a point where we shall be able to afford this device. And I'm sure GNCI, once they feel, once GNCI sees the market for it, it's likely they get it. And I can assure GNCI, from a marketing standpoint, the impeller would be easier to sell than the ECMO. It has more use for us in cardiology and cardiovascular medicine and surgery. So I would urge GNCI to look into the impeller device and bring it into Nigeria, and we shall start to use it. It just takes starting. And like I've told many people, most of the things we get usually donations. Somebody, some charity, somebody will donate it once it is available for us. And then we start to use, then people get used to the device, volumes increase, and more people can buy. But yes, it is the way to go.
Thank you, sir. Thank you, sir. I will allow Dr. Faleshe and Dr. Iseko, who just posted something on the chat, to make a few comments. And while before that, Dr. Faleshe just asked if helium cylinder is available and if it can be refilled anywhere. I think we have the capacity to do that, but if you have need of that, please, you can reach out to us. You can reach out to us. We usually have to bring it from outside the country, and it goes through some clearance that is required at the port, but we have the capacity to do that. So Dr. Faleshe and then Dr. Iseko.
Okay, thank you. I just wanted to respond to Dr. Joe's comments. There's the world of the theory and the real world. In the real world, the IBP is not outdated. Yes, there are devices that are more efficient and effective and also more expensive. Right now, the IBP does do a good job of flooding the LV and increasing coronary perfusion, reducing the supply demand. We are seeing it very effective, and there's plenty of evidence to show that the IBP is very effective. Yes, there are advances. As we advance, as Dr. Johnson said, we may get to a point where ECMO and impeller are also available. But by no means is the IBP outdated. It is a very useful device, and that's why we're all here today listening to this presentation. Thanks.
Thank you, Uncle Dr. Johnson. Thank you so much for a great presentation, and thank you everybody for the comments. I've used IABP before, and it's quite helpful. It really does help coronary perfusion, especially when you've had a very tough, complex coronary case. So, saying that it's outdated, I'm not sure about that. It's not. You can say you have a newer car available, does not mean the old car is no longer useful. So, in West Africa and Nigeria particularly, this will likely be the most feasible and pragmatic device for us to use over the next 5 years. Impeller will come in definitely, yes. And then until insurance takes hold, real insurance takes hold, then maybe we can have it as routine. But IABP very much used. Even in those centers where impeller and ECMO is available, IABP is still used very much so in the eye. So it's not to write it off and say no. It's very much useful, very much available. And even though the starting cost may be a bit high, the recurrent costs are fair enough to be able to manage what we have. And luckily, most of the newer devices of the IABP also still supports. The newer balloons also still support the older devices. So, and that is quite helpful. We do have the bigger balloons in our center from JNC as well.
Thank you, sir. I think is there any other question? Okay, this might be the last question.
I have a question.
Is that Dr. Obe?
No, Dr. Johnson. I have a
Okay,
question.
Dr. Johnson.
For Dr.
Okay.
Iseko. I want to
Okay.
understand what real insurance means. Is he saying that insurance is fake? I just need to understand what he means by real insurance.
So those are political questions. I'm sure
And
you
you're
know
in Abuja, the capital of politics. So
exactly.
I understand. No comments.
I've had to represent at several meetings, so the rest I cannot see on camera, but we'll leave it at that.
Okay, sir. Dr. Napoya. Good afternoon, sir. Dr. Napoya can unmute to ask your question.
Okay, good afternoon. Thank you very much, Dr. Yemi Johnson. Brilliant presentation as usual. I'm very excited about the use of intra-aortic balloon pump. Unfortunately, it's not because of the size of the balloons. It's not in general use for much younger patients, especially for children. So I want to know if there is the availability of smaller balloons right now to be used for the younger patients, especially children. Thank you.
I think I'll let Janice answer that because I don't know anything about children. But I know the smallest size balloon is 30.
Okay, let me quickly just show a quick slide. So we also have a 25cc balloon, and we usually make sure we have this card in facilities that use this sizing card so that you can decide. Currently now what most facilities or half of the facilities of our install base use is a linear catheter, but like I was making reference to the bigger balloons which Dr. Iseko also mentioned, that's the mega balloons. The most, like Dr. Johnson just said, we have 30cc, which is what most people know as the smallest, but Getting also offers the 25cc. However, we have not brought that into the country because we've not had any request for that. But Dr. Nokoya, maybe after this call, if this is required, particularly for you looking at your practice, we can make arrangement to have one or two of that in country for you when you have need of it. I hope that addresses your question, sir.
Yeah, we'll have a discussion after. Thank you.
Okay, sir.